Now we'll go into the osteoradionecrosis. Osteoradionecrosis is derived from the Greek words osteon meaning bone, necros means dead, osis means condition. Destruction and death of the bone tissue such as from ischemia, infection, malignant neoplastic disease or trauma. The etiology. Doses above 50 Gray are required to cause this irreversible damage. Dental extraction and denture trauma after radiation therapy are responsible for the occurrence of osteoradionecrosis. When we look to the risk factors, it depends upon the following: the primary site, the stage of the malignancy, proximity of the tumor to the bone, dentition, type of treatment, time of radiation dose, delivery. Radiotherapy, mode of delivery, its location, and volume of irradiated tissue. The status of the oral hygiene. More poor the oral hygiene, more incidence of osteoradionecrosis. And surgery. We go into the pathogenesis. It was first described by Marx in the year 1983 as hypovascularity, hypocellularity, and local tissue hypoxia. Marx theory: following radiotherapy, hyperemia, that is increased redness, inflammation, and endarteritis, that is inflammation of the arteries, occur in the mandible, periosteum, and the related soft tissues. This eventually results in thrombosis, cellular death, progressive hypovascularity, and fibrosis. The irradiated block becomes less cellular and lacks fibroblast, osteoblast, and undifferentiated osteocompetent cells. Mandible is more prone to osteoradionecrosis, which occurs in 5 to 15% cases than maxilla. This is because the mandible is supplied by inferior alveolar artery, whereas maxilla is supplied by the anterior, middle, and posterior superior alveolar arteries and collateral blood vessels. There are three types of osteoradionecrosis. The type 1 osteoradionecrosis is seen soon after the radiotherapy due to the devascularization resulting from the combined side effect of surgery and radiation. Type 2 osteoradionecrosis occurs after many years after radiotherapy following a known traumatic episode. These results from vascular endarteritis of nutrient vessels of the jaw bone combined with poor wound healing of surrounding soft tissues. Type 3 osteoradionecrosis occurring between 6 months and 3 years post radiotherapy. Just from the vascular, type 2 osteoradionecrosis occurs after many years after radiotherapy following a known traumatic episode. These results from vascular endarteritis of nutrient vessels of the jawbone combined with poor wound healing of surrounding soft tissues. Type 3 osteoradionecrosis occurring between 6 months and 3 years post radiotherapy with no specific preceding traumatic episode. Now we look into the clinical features. Mandible is more affected than maxilla due to microanatomy and less vasculature. Posterior part is more affected than the anterior due to the radiation treatment for tumors in this region. Patient complains of pain, bad breath, and food lodgement in the affected area. On examination, the bone is exposed and associated soft tissues are ulcerated and necrosed. Additional findings such as intraoral or extraoral fistula, mandibular discontinuity, or evidence of secondary local or systemic infection may also present. Loss of mucosal covering and exposed bone are hallmark of osteoradionecrosis. Now we go into the treatment. The treatment is aimed at the removal of the necrotic bone, enhancement of the vascularity of the remaining radiation damaged tissues. There are 3 stages of the treatment. The first stage involves the improved local hygiene, antibiotic mouth rinses, local debridement, sequestrectomy or saucerization, marginal resection, hyperbaric oxygen therapy, 30 dives, and oral antibiotics. Stage 2 is followed by all of the above under the stage 1, and segmental resection, free flap reconstruction. Stage 3, segmental resection, free flap reconstruction, hyperbaric oxygen, and antibiotics. When looking at the management, initial treatment, control of the infection if present. Gentle irrigation of the soft tissue margins removes the debris and reduces inflammation. Supportive treatment with fluids and liquid or semi-liquid high in proteins and vitamins. Pain may be controlled with narcotic analgesics, bupivacaine, alcohol nerve blocks, and nerve avulsion, rhizotomy, hyperbaric oxygen therapy, pentoxifylline, clodronate, antioxidant, that is vitamin E. Hyperbaric oxygen therapy. The hyperbaric oxygen therapy was introduced by Dr. Greenwood, Gilchrist, and Maynos in the year 1973. Due to hypovascularity and hypocellularity in both hard and soft tissues following irradiation of the bone, the hypoxic compromised tissues challenged by the traumatic episode failed to heal. Delayed fibroblastic activity in forming collagen results in chronic non-healing wound. These wounds get infected secondarily. The goal of treating osteoradionecrosis is to overcome hypoxia and increase the vascularity of the tissue. The hyperbaric oxygen therapy consists of 100% oxygen administered more than 1 absolute atmospheric pressure. The methods of delivery. It is administered in a chamber called hyperbaric chamber, which may be monoplace or single patient or multiplace or multiple patients. Each session ranges from 90 to 120 minutes, where patient breathes 100% oxygen at 2 to 2.4 atmospheric pressure. Each session is termed as dive. A total of 20 to 30 dives spanning 5 days a week was planned pre-operatively. Now we look into the pentoxifylline and vitamin E. The association between the pentoxifylline and vitamin E. Pentoxifylline lowers blood viscosity, increases tissue oxygen level, reduces fibroblast proliferation, and increases collagenase activity. It is used to treat intermittent claudication. Vitamin E is an antioxidant. It is used to treat advanced cases of osteoradionecrosis with promising results. It is believed to promote healing. Prevention of osteoradionecrosis. Every patient should have dental assessment prior to radiotherapy for best outcome during treatment. Extraction of all teeth before radiotherapy is recommended. Removal of all teeth with poor prognosis less than 5 years is recommended. Removal of mandibular molars in fields over 60 gray unless patient has excellent oral hygiene. Now we look at the preventive regime. If mouth becomes too sore during radiotherapy, a soft brush is necessary for a time, supplemented with chlorhexidine mouthwash. In addition, a high fluoride toothpaste in splints for 10 minutes every day or alcohol-free fluoride mouth rinse. Saliva substitutes should be at neutral pH. Extractions after chemotherapy. Recommendations. 0.2% of chlorhexidine mouthwash prior to the extractions, amoxicillin 3 gram orally, 1 hour prior to the extraction, or clindamycin if it is allergic to penicillin. It is administered in the dosage of 600 mg. Post-operative amoxicillin 250 mg thrice a day or metronidazole 200 mg thrice a day for 3 to 5 days. Minimal trauma, simple extraction of mobile teeth, an experienced operator, pre-operative hyperbaric oxygen therapy for lower molars in areas of high radiation, review after 5 days, and weekly review until healing is complete is the major prerequisites for a successful treatment of osteoradionecrosis. Now we enter into the osteochemionecrosis. Bisphosphonate-related osteonecrosis of jaw is a condition where necrosis of the jawbone occurs subsequently to dental infection or therapy in a patient being treated with bisphosphonates. Now we look into the diagnostic criteria for the bronch. Currently on bisphosphonate therapy or a history of bisphosphonate therapy. Exposed necrotic jawbone, non-healing for more than 8 weeks. No history of radiation therapy to head and neck region. Uses and mechanism of bisphosphonates. Prevention and treatment of osteoporosis in post-menopausal women. Increased bone mass in men with osteoporosis. Treatment of Paget's disease of bone. Hypercalcemia of malignancy. Osteolytic lesions, multiple myeloma, like multiple myeloma. Bisphosphonates inhibit osteoclastic activity. Because of the osteoblastic activity coupled tightly with the osteoclastic activity, it suppresses the bone turnover. It is administered in cases of osteoporosis and cancer affecting the bone like multiple myeloma and metastatic tumors. The side effects are impaired osteoclast function, bone becomes too dense, avascular bone necrosis. The stages of the bronch. There are 3 stages of the bronch. Exposed bone with absence of pain and infection. Pain may be associated with suppuration and intraoral sinus tract formation. Extraoral fistula, exposed necrotic bone extending beyond the region of alveolar bone, and pathologic fracture and osteolysis. Now we look into the treatment of osteochemionecrosis for 3 groups of patients. For group 1 patients, to treat the active oral infection, impacted teeth, eliminate the teeth not able to be restored, and periodontal grade 1 with bad prognosis. Dental appointments should be given every 6 months, 2 prophylaxis per year, endodontic and caries treatment. Group 2, less than 3 months of therapy, treatment stage than the group 1, greater than 3 months of therapy, avoid surgical procedures, that is endodontics, scaling and debridement. Administer systemic antibiotics, simple dental extraction with small bone manipulation and survey until healing. Third group, the group 2 with similar with us, group 2 with greater than 3 months of therapy, diagnosed with CT, necrotic bone extirpation with small trauma, chlorhexidine 0.12% or mouth rinse with hydrogen peroxide, antibiotics in monotherapy or in combined. Analgesics are prescribed, soft layer on oral prosthesis until progresses until improvement. I thank you all for patiently listening to this presentation. Thank you.